Well, cataract is one of the most commonly performed surgery, and it's performed under topical anesthetic as a day case. On average, it takes about between 10 and 15 minutes, unless it's a complex case, in which case it might take a little bit longer. The surgery is performed using an ultrasound. So technique is called phacoemulsification. That's the most commonly used technique. There are others, but they're less used now. So phacoemulsification uses very low frequency high frequency ultrasound, and we use quite a low power, so the damage to the surrounding tissue is minimal. So the part of the procedure with cataract is involved removing the nucleus of the lens. So we break it down into very sort of fine emulsified structure and aspirate it with the probe. So during this process, it is possible to injure the bag where the lens sits. And if that happens, we call it posterior capsule rupture. So that's one of the most common complications, and the incidence is quoted as 1 in 100. In a more complex case, the incidence may increase to 2 to 3%. And if that happens, then the lens will be required to be removed from the back of the eye. So we will need to convert the procedure and add the step that we call vitrectomy. So the lens will be removed with a gel that fills the cavity of the eyeball. So that's the most common one. The most dreaded complication is the infection, and we call it endophthalmitis. And the incidence of that is reported as 1 in 1,000 after cataract surgery. So the current hospitals have very stringent infection control, and everything that we do is very strictly protocolized. We use every single measure to minimize the risk of infection, but nevertheless, despite all those measures, 1 in 1,000 patient may develop the endophthalmitis. If this happens, the most important thing is for patient to let us know as soon as possible, and we do warn them to let us know about any pain, any blurriness of vision, anything that they would not expect after surgery, especially if it's getting worse, not better after surgery. So that's the most dreaded one. Another complication that is very rare but very significant is something that we call suprachoroidal hemorrhage. That usually happens if there's a discrepancy between the blood pressure that being elevated and soft eye during the intraocular steps, when the pressure in the eye becomes quite low. So this discrepancy leads to rupture of one of the vessels in the posterior part of the eye, and leads to sudden and very big hemorrhage, which can potentially, if not stopped on time, lead to long-term impairment of vision. Not all of them do, but we try to recognize this as early as possible, and sometimes we may have to stop the procedure and pass it to vitreoretinal surgeons, and we receive a lot of referrals from our colleagues to try and deal with that if required. So, and there are smaller complications that present. So these will include unexpected refractive errors. So that is when we calculate the lens and estimate the power that is required for patient to be able to see the distance without glasses, or in case of multifocal IOL, not to have glasses for distance and near. But despite those accurate calculations, occasionally we may have an unexpected refractive surprises. And in this case, there are a few options that we will discuss with patients, but briefly they will include exchange of the lens, second piggyback lens, or even additional laser refractive surgery to compensate for that. The lens itself, rare occasions, there may be instability of the lens in the bag, when the lens may either pop out and may need repositioning, or if there is a breach in the capsule, then it may not be perfectly centered. And in that case, we may need to reposition the lens and move it sort of to center it again. So these are probably the most common complications. The other one that is probably worth mentioning is a transient problem of spike of intraocular pressure within the eyeball after interventive procedure, and also inflammation. Sometimes, especially if there's a predisposing condition such as previous surgery, diabetes, or inflammatory history with uveitis, then the response may be a little bit more marked than on an average eye. And in that case, we may need to add additional treatment after surgery. And of course, as long as patient lets us know early on, we'll be able to tailor the treatment and deal with the complication as they come. So the risks of posterior capsule tear is 1 in 100. That's a national average. The risk of severe infection is quoted as 1 in 1,000, and that's again average national figures. And risk of severe suprachoroidal hemorrhage is also 1 in 1,000. The risk of having a small spikes of intraocular pressure and severe anterior uveitis are all added less than 5%. So overall, cataract surgery is a fairly safe procedure, and over 95% of patients will be aware of improved vision. Of course, the visual improvement will depend on the state of the retina, and if there's pre-existing conditions such as age-related macular degeneration or diabetes or previous retinal detachment surgery, be that for macular hole or macular off retinal detachment, then the outcome will depend on what the previous state of the retina was. So the factors that might influence is mainly pre-existing history. There are certain conditions that may increase the stability of the lens, such as pseudoexfoliative syndrome, previous history of trauma, previous history of uveitis when there's a scar formation around the lens, previous retinal surgery when the gel has been removed from the back of the eye, very high short-sightedness, which also destabilizes the vitreous and makes the iris lens a bit less stable. But overall, the risk factors are conform to the figures that I've said earlier.